Good morning, everyone. I thank Ramesh Hospitals, Ramesh sir, and all the team for inviting me and giving me an opportunity to talk in this CME. So, I'm a pediatric cardiologist. So, I've been asked to talk on what about the pediatric heart and what all we need to take care of that pediatric heart. The learning objectives of my talk would be understanding pediatric cardiac physiology, the fundamentals, distinguishing between innocent murmurs and a pathological murmur, what are the applying screening strategies for safe clearance of asymptomatic children into the OR, recognizing myths in congenital heart disease management and apply evidence-based practices, implement prevention strategies for hypovolemia, hyperkalemia, and hypothermia, apply appropriate endocarditis prophylaxis, and enhance perioperative communication and teamwork. So this is a wide group of audience. So you could be a cardiologist, a pediatrician, a surgeon, or an anesthetist, right? All of us are here. But our roles differ based on what we are. For a cardiologist, it could be risk stratification, physiological assessment, monitoring. For a pediatrician, we have to screen, detect, family education, give them appropriate what to expect to the family. As a surgeon, we need to anticipate complications in a pediatric child, management of blood products, coordination within the team, and as an anesthetist giving anesthesia to these pediatric patients, we need to know the physiology, airway, what is different in a pediatrician for a pediatric population, the hemodynamics and monitoring. We can say there are two distinct populations of children who are coming into the OR. One is the normal child and the other one is a child with congenital heart disease. Okay, let's see these two groups, how do they differ? Basically, when we talk of children into the OR, they differ from the adults. As we know, the cardiac output is the product of heart rate and stroke volume. In adults, the cardiac output is stroke volume dependent, whereas in children, it is actually heart rate dependent. So, if your heart rate in a child in the OR decreases, that means the cardiac output is significantly low. Okay? So, bradycardia in children can cause cardiac arrest. Be careful. The neonatal or the pediatric myocardium is different, or it is very immature compared to the adults. They have a fewer contractile elements, so they have reduced force of generation. They have a flatter Starling curve. Okay, so if you give more stroke volume, the cardiac output is not going to improve, unlike the adults. The sympathetic innervation is not complete. They are RV afterload sensitive, and they have a higher metabolic rate, so their cardiac reserve is lower in smaller children. The RV characteristics are also significantly different. They are thin-walled RV. It has a limited contractile reserve, highly sensitive to afterload. So any change in pulmonary vascular resistance, like hypoxia, will increase the PVR, hypothermia will increase PVR, and hypercarbia. We need to be very careful. Always, a child is not a small adult. Okay, you can't put the same formulas of an adult into a small child. A 7 kg child versus a 70 kg is completely different. We can't put the same thing. So there are a lot of physiological changes, and that's why this topic is here. In the normal children, we do see on our OP practice, or as a pediatrician or an anesthetist, we auscultate, we hear murmurs. So what is an innocent or a safe murmur? If you look at the data, sometimes we hear about 60 to 70% of children, a normal child can have a murmur. So all murmurs are not dangerous. Okay, so just because a child has a murmur, just don't think that he has a congenital heart disease. An innocent murmur is a soft blowing, soft quality early or mid systolic murmur. There is not associated with any clicks. The second heart sound split is normal. The child is asymptomatic and normal pulses. So this, in the innocent murmurs, we don't need to evaluate further. What are the pathological murmurs which we need to evaluate? Anything which is loud, okay, harsh, holosystolic or pansystolic, any diastolic murmur, we need to be careful. Any thrill, we have to be careful. Abnormal split second heart sound, we need to be careful. Okay, the child is symptomatic associated with a murmur, be careful. Okay, look at the pulses, lower limb pulses, is there a difference? Any weak lower limb pulses, need to be careful. Any hepatomegaly, suggestive of right heart failure, be careful. So these are the red flag signs, especially when a child whom we take before a surgery. child who's having decreased effort intolerance, okay, compared to the peers. To the sibling, the child is getting easily fatigued, you look after it. Any history of syncope or pre-syncope on, especially on exertion, not at rest, and exertion is a red flag, okay. Exertional dyspnea, I already told. Failure to thrive, family history of sudden cardiac death, okay. This is a red flag sign when before we take this child into the OR. Any signs of heart failure is also a red flag sign. The second group of children is the group with congenital heart disease. In this, there are a lot of myths and what before we take these children for surgery. So a cyanotic heart disease, a lot of them, or a lot of anesthetists or pediatricians or the cardiologists are very scared to take them into the OR, okay. But if we maintain the preoperative saturation, or if we ensure the saturation is maintained, okay, then those children we can safely do any like a hernia surgery or any phimosis, any risk, any emergency needs to be done, we need to do. But what we need to remember is whatever the baseline saturation, for example, a tetralogy has a baseline saturation of 80-85%, we ensure that that saturation is maintained. We need not aim at 9500, which is not possible, okay. So also we also look like suppose ventricular septal defect is there. If we give too much of oxygen, that will increase the left to right shunt. So it indeed can worsen the child. And not all cyanotics need prostaglandin infusion, okay. That's a myth. So only it's the duct dependent circulation lesions which need a prostaglandin infusion. If you are in doubt, you can confirm with a cardiologist. Induction agents, yeah, we should be very careful, especially those which reduce the systemic vascular resistance, SVR, okay. So the safer one would be something which can improve your, keep your systemic vascular resistance at bay. So ketamine most of the times keeps up this thing. But whereas if you use isolated midazolam or when we use propofol, it can cause significant fall in pulmonary it can significantly cause fall in systemic vascular resistance. Another very common mistake which we miss is anticipating hypovolemia. In children, they are very, very sensitive to hypovolemia, okay. One of the leading cause of cardiac arrest is hypovolemia. So the prevention strategy would be anticipate the losses, be prepared to have packed cells, FFPs before any incision, okay. If the child is having borderline, he is borderline anemic, okay, don't think like an adult. Child are very sensitive, so keep backup blood transfusion, always monitor blood pressure, heart rate and saturation and urine output. Other two mistakes which we commonly make in the OR is not noticing hyperkalemia and hypothermia. Hyperkalemia, yes, because the reserves, the children reserves are so low, okay. Any massive transfusion, as you know, a packed blood cell, if you keep a PRBC transfusion, delayed transfusion, or older transfusion beyond 72 or 96 hours, the amount of potassium in that bag is going to be significantly higher, okay. It rises almost 1 milliequivalent per liter every day. So a normal serum potassium, if you say 3.5 to 5.5, stored bag which has more than 96 hours which is stored, a old PRBC, if you transfuse, the potassium in that blood is almost 8 to 9 milliequivalents, and it continues to rise. So be very careful, especially in children, when we are transfusing packed blood cells which are of older age, more than 7 or 10 days. So always transfuse fresh PRBC whenever is possible. Hypothermia, very common in neonates and children, okay. The pediatric surgeons and all of us anesthetists, we all are very careful, but as that needs to be red flagged into us, okay. It can occur to 60 to 90% of children when we are in the OR. So how do we prevent? Okay, it can be reduced, hypothermia events can be reduced to less than 10% by ensuring that we have a proper pre-warm the OR, making appropriate temperatures 22 to 24 degrees Celsius. Okay, we can keep warmer blankets, okay, avoiding minimal skin exposure, and ensuring not as soon as you finish the surgery, even in the post-op, in the post-op ICU, we should continue warming and keeping these children away. NPO guidelines, it's not like adult, all of, we write midnight, NPO from midnight or like that, okay? In children, we have to be little liberal, okay? There are various guidelines where we need not have 6 hours NPO, okay? Especially neonates and small children, okay? We can give clear fluids for up to 2 hours, okay? Some water, and also breast milk is acceptable for up to 3 to 4 hours, okay? And definitely, as in adults, we don't give formula feeds or solids for up to 6 hours. Liberal NPO guidelines is very, very critical, especially in children like with cyanotic congenital heart disease. If you keep them nil per mouth and they get hypovolemic, they can end up in a cyanotic spell. Even pre-cardiac surgery, okay, we have to be very, very liberal in giving, keeping these children with NPO, okay. So for a congenital, if you are taking up a congenital heart disease patient, what we need is, number one is definitely a skilled personnel for monitoring. Continuous ECG monitoring is recommended in the operation theater. ECG monitoring along with SpO2. If you are ventilating, EtCO2 monitoring is very important because as you know, if PCO2 increases, it can increase the pulmonary vascular resistance and worsen the underlying cardiac cause. Maintain the core temperature of a child. Never allow hypothermia in the OR. Okay, if possible, if it is a major cardiac surgery or a major cardiac surgery, definitely we put arterial lines, but a major long surgery, pediatric surgery also, better to have an arterial line and ensure we maintain the potassium, hematocrit, glucose in the OR. Another main question is, do all children require infective endocarditis prophylaxis? Because this is one of the most common reasons when a pediatrician or anesthetist or a surgeon think of, okay? So the current guidelines is that infective endocarditis prophylaxis is recommended only for very, very limited number of children. The reason behind it is that the amount of microbia within the mouth, and the simple thing like a general daily brushing causes significant microorganisms, okay, into the bloodstream. That itself is a very it's a normal thing. So for infective endocarditis prophylaxis, we need only for 4 high-risk conditions which needs infective endocarditis prophylaxis. That is, those who have previous history of endocarditis, a child with unrepaired congenital cyanotic heart disease needs endocarditis prophylaxis. Any patient who have a prosthetic valves, even in adults, okay, any patient who have a prosthetic valves need a infective endocarditis prophylaxis, and also the complex cyanotic lesions, okay, unrepaired complex single ventricle. These are the only 4 high-risk category which needs infective endocarditis prophylaxis. And we all know the dosing. We should know for both penicillin sensitive and penicillin allergic patients. And it's a single dose. So not to give too much of infective endocarditis prophylaxis, otherwise we'll be ending up in having microbial resistance. We also, when we take care of children, we also need to understand the balance between the pulmonary vascular resistance and systemic vascular resistance. And as we know, the pulmonary vascular resistance is 1/10 of the systemic vascular resistance. So the goal for a congenital heart disease patient is to maintain the balance, the ratio, what was present before we take the patient into the OR. Continue to have the same oxygen saturation, ensure the CO2 is not too high. And if you do that, the PVR-SVR ratio will be maintained. This we know, if increasing FiO2 will decrease the pulmonary vascular resistance, so it will increase the left to right shunt, so we need to balance. Increasing PCO2 or hypercarbia will cause increased pulmonary vascular resistance, so you will have a right to left shunt. And again, increasing temperature, okay, will cause fall in PVR and the vice versa. So as a preoperative assessment, the key questions is, in a child with congenital heart disease, is the cardiac diagnosis a simple or a complex? Whether the child underwent a cardiac surgery before, what is the current hemodynamic status? Is he hemodynamically stable? Is the child is he on any ACE inhibitors, diuretics, digoxin, which can worsen the cardiac or the surgical outcome? And is there any history of recent infections? Okay, any viral infection, or is there any fever? These are the key questions which we take before we take a child to the surgery. Communication is very important because it's a teamwork. The communication between anesthetist, pediatrician, okay, surgeon is very important. So before surgery and during and after surgery is very important in these children. So the cardiologists, pediatricians, surgeons, and anesthetists, they have different roles, and they, based on what is their role, they need to communicate and ensure that the child is coming out. For any successful surgery, it's a teamwork. So it's always better to have a checklist. Okay, we have a pre-operative checklist. In a pre-operative, you know the diagnosis, brief the team, check the vitals, establish monitoring, ensure that everything is ready, blood products are ready. In the intra-op, ensure maintain normothermia, avoid any bradycardia, monitor for any arrhythmias, anticipate bed loss. Okay, you're seeing then ensure that blood is there, monitor that monitoring temperature in a child is very important. And it's not that once the surgery is over, we don't leave them. Post-op also, we need to continue to monitor, ensure vitals are all checked, okay? Labs, potassium, blood gas are very important, and we need to have a clear communication. So communication failure is one of the most common mistakes. So if we have a structured briefing, who, what, when, and where, definitely that communication failure would not happen, and it would help in improved outcomes in these children. Also, inadequate monitoring is one of the important mistakes which we perform, which we do in children post-op. So we have to have a continuous monitoring in these children. Also know who are at risk of, children are at risk of hypoglycemia. So because they have limited glycogen stores, and if you have a prolonged surgery or we have a prolonged NPO period, okay, prolonged cyanotic babies, all this can worsen the cardiac output. Hypoglycemia can worsen cardiac output. So we need to have a prevention strategy. As I told you, we have a liberal NPO, IV fluids, pre-induction checkup, and a post-operative monitoring. If you have an active URTI, do you operate on these patients? Okay, definitely they are at a higher risk. Based on the severity, if the child has a fever of more than 38 degrees Celsius, better to postpone the surgery. Mild URI, but the child is afebrile, we can take up based on the risk. Okay, if the child is having residual cough, it's always better to wait, especially in pediatric cardiac. When we take a child into the OR and they put the patient on cardiopulmonary bypass, they can react to the cardiopulmonary bypass and they can have worse outcomes. Okay, so it's better to delay the surgery if they are having viral infection. So a few case examples. A child with innocent murmur, 8-year-old child with innocent murmur, whether we take the patient for surgery or not, what would be the next follow-up? The decision would be to proceed, basically because as I told you, 30 to 70% of these children murmurs can be innocent. A 5-year-old child with repaired tetralogy of Fallot, child wants to have a dental extraction. Do we need an endocarditis prophylaxis? No, it's already a repaired tetralogy. Okay, you don't need an endocarditis prophylaxis. Okay, so you just continue home medications, routine anesthesia, and all that. A child with unrepaired transposition of great arteries. Okay, he's very blue, but he has a hernia. He has an obstructed hernia. He comes to us. What do we do? So, as in the OR, the key decisions would be we have to operate because it's an emergency, but ensure the saturation maintains the baseline saturation. Okay, give him endocarditis prophylaxis. Ensure we involve the cardiology team also, and in these patients we have to avoid dehydration and increase anything which increases afterload, because the RV is the systemic ventricle, so we have to be very careful and also avoid hypothermia in these patients. Any child who is having a complex heart disease with residual lesions, suppose a 6-year-old child with hypoplastic left heart, but there are some issues like small residual issues. He has got repaired, but there are some mild residual issues like aortic regurgitation. For that patient, yes, does he need endocarditis prophylaxis? Yeah, because there are some valvular regurgitations. It's a cyanotic patient, complex lesion. So endocarditis prophylaxis is indicated. In these patients, again, hypovolemia, we have to avoid hypovolemia, ensure we monitor the central venous pressure and coordinate with the cardiac team. So another case scenario, a 3-year-old child, there is no cardiac history presenting for any ear surgery. On the day of surgery, child develops fever and cough. Mom says just a cold, what should we do? Should we proceed, or should we postpone, or should we consult a surgical anesthesia team and evaluate urgency? What do you think? The probable answer is, yeah, because there is significant fever, cough, cold, probably we need to better to wait, okay, because there is a risk of airway reactivity and with these patients, and risk is higher. A 5-year-old child, another scenario where 5-year-old child with repaired VSD presenting for same dental cleaning. Should we give endocarditis prophylaxis? Answer is no, it's more than 6 months, so they are at low risk not to give endocarditis prophylaxis. A 9-year-old child with ASD, asymptomatic and normal exercise tolerance. There is a soft ejection systolic murmur. No other findings. He has come for an elective surgery. What do you do? Do you need a further evaluation? Probably ASD is a lower risk, and with a normal ECG, you can safely take up for the surgery. So, to summarize, as a cardiologist, risk stratification is very important. Okay, identify who is at high risk, who is at low risk, assess the anatomy, assess the hemodynamic stability for a surgery. Okay, always the key principles would be, the adult principles don't apply in pediatrics. Okay, so pediatrics, as I said, we have a different risk profile. Like we have to ensure that we have to avoid hypovolemia, hyperkalemia, hypothermia, hypoxia, and all that. And don't think of the coronaries, especially in children. As a pediatrician, we have to empower ourselves to clear safely. Okay, we should not overjump and think all murmurs are pathological. So most 30 to 70% of the murmurs in children are innocent. Okay, we need to document them and ensure that the red flags in these children are not missed as a pediatrician. As a surgeon, yeah, preparation before incision is very important. Okay, if you are anticipating any blood loss, ensure that we have appropriate blood products ready, okay, in a bedside. Ensure that we plan the surgery, okay, in these children. I've also already discussed about endocarditis prophylaxis. We need to be very careful. Preoperative assessment, we have to have a proper checklist, and perioperative guidelines are all well given by a lot of this thing. So the key takeaways from my talk is, in children, the physiology is different. Okay, children are heart rate dependent to maintain the cardiac output, whereas not like an adults where they are stroke volume dependent. Not all murmurs are pathological in children. Okay, most of the murmurs in children, the soft murmurs, are physiological. So you just document and you can clear for surgery. Hypovolemia, be careful. It is one of the most common cause of cardiac arrest. So anticipate and ensure we are prepared. Hypothermia also can kill the child in the OR, okay, or in the post-operative. Be very careful. By planning safe OT practices in these children, definitely we can avoid hypothermia, and multimodal prevention strategies are indicated. Not all children require endocarditis prophylaxis. As I told you, only 4 groups of children require endocarditis prophylaxis. We need to have a clear communication, structured team briefing before each surgery, and especially collaboration between all the subspecialties or specialties is necessary, especially when we are dealing with a child in the OR. Thank you.